We'd like you to welcome to our EUS live course of Interventional EUS this morning. We know we got a lot of participants from across the world. I'd like to hand over to Dr. Vinay for an introduction to this course, and then we'll move on.
Thank you, Rahul, and good morning, everyone. I welcome you all to our last live session. We have been experimenting with this format for past 4 months, using it as a teaching module, trying to see whether we can impart education, live education pieces to students and to other colleagues who are interested. So I'm happy to say that today is the interventional EUS part, and we have some of the extremely senior and well-known people. Are you seeing my screen?
Yes, Vinay. Yes, please go ahead.
Okay. So welcome to this course, and as you can see here, this teaching activity has been supported by a lot of senior teaching faculty who are doing EUS for a long time. So the activity is organized by the Indian EUS Club at the School of EUS, and we have the Hong Kong Society of Endosonography, the Gastroenterology Society of Singapore, ACED from Colombia, European EUS group, the Taiwan Gastroenterology Society, and the Kenya Gastroenterology Society. Of course, SGEI is also actively participating in this. So it's an educational effort, combined educational effort from a lot of societies. And I thank people who are joining this. So from Hong Kong, we have our friends, Anthony Teoh, Professor Y.T. Lee, the president of Hong Kong Society of Endosonography, Raymond and Shannon. Shannon joins us today. So Anthony, YT, and Raymond were there for the previous live EUS also. Shannon is a young assistant professor at Hong Kong CUHK, excellent endosonographer. She joins us today. From Singapore, we have, of course, Lawrence, who has been a big support to all these educational activities in Asia over the past decade or so. Thank you, Lawrence. And Anting Leong with us from Singapore, who is going to give a lecture. He was there last time also. So myself and Anting Leong both are sharing one session together. From the Gastroenterology Society of Taiwan, we have Professor Hsiu Wang joining us this time. Hsiu is a very dear friend, a colleague from Asian EUS group, and very active, not only in endosonography, but pancreatability endoscopy, ERCP, and other areas. Also, he loves to teach and has fantastic publications. So welcome, Hsiu, to this meeting. We have from EG, the European Group of Endoscopic Ultrasonography, Professor Claudio De Angelis. Claudio is a very senior endosonographer who has been championing the concept of EURCP for past decade or so. So we will hear from him about EURCP today. Then we have from Gastroenterology Society of Kenya, Professor Eli Ogotu. He has been joining us in our previous meetings also. Thank you, Eli, for joining us today. From ACED Colombia, my dear Professor Lazaro Arango is there. Unfortunately, he just now messaged me that he has some emergency, so he will not be joining, but his colleagues are there with us on this program. Thank you, Lazaro, for being part of this meeting. And then, of course, we have the Indian EUS Club and the SGEI represented by my colleagues and friends from India, all great endosonographers, great teachers, Sandeep from AIG Hospitals, Rajesh from Medanta Hospital, Matthew from Lizzie Hospital, Koshi. Amol joins us today. He will be showing a case. Amol is from Dinanath Mangeshkar. He needs no introduction. A great name in third space and EUS. Praveer joins us again from SGPGI Lucknow. Surinder joins us again from PGI Chandigarh, and Sudipta joins us from CMC Vellore. Nilay is joining this time again, a very senior endoscopist, endosonographer, ERCP man from Zydus Hospital, Ahmedabad. Pankaj, my dear friend, joins us from Surat. And then we have Manoj from Sum Hospital, Bhubaneswar, and Chalapati Rao from Vizag. So we have a galaxy of people joining us and helping us in this educational effort from India. And I thank SGEI for providing support. The course objectives are to learn the basic technique. So like last time, we are not going into the details or the theory of it. We want to learn the technique. So learn the techniques and maneuvers needed to perform various interventional EUS procedures. We have kept a lot of video lectures also. The aim is to have to understand how the procedure is done. So with that, I hand over back to Rahul.
Yes.
Rahul?
So good morning, everyone, once again. Thank you for joining us from across the world. First, we would like to welcome on stage the moderators, Professor Lawrence from Singapore, who is the head and professor at the National University. Thank you for coming this morning. Unfortunately, Lazaro from Colombia could not join us this morning. So we're going to move live to Professor Supo Wang, who is the professor and head at the National University of Taiwan. So you're live.
So good afternoon, everyone. I'm Lawrence from Singapore. So it's a pleasure for me to be able to moderate this first session, which is a live demo from National Taiwan University Hospital. And the live demo will be headed by Hsiu as well as his colleagues from the endoscopy center there. I believe that he's going to share with us his case and also I think go through the procedure in details. So I think before we start, maybe I will just do a few housekeeping, go through a few housekeeping tasks with all of you. I think later on, we as Vinay said just now, we do want this to be really practical as people, I think we'll be very happy if we can all learn something out of the workshop today. So I think plenty of questions, plenty of interaction and so forth. The way to do it is because this is a Zoom, a webinar meeting. So I think unfortunately we cannot have sort of voice exchanges. So what you can help us with is to type in the questions in the Q&A section, okay? The Q&A below, not the chat, so that we can actually go through the question and quickly delete it once the questions are actually answered by Professor Wang's team, and we can just go on to the next question. Okay, so if you can help us type in the questions in the Q&A section. So without further ado, maybe I can just pass this over to Hsiu to kick off the session.
Okay, thanks, Lawrence. I'm Hsiu Wang from National Taiwan University, and I will introduce my team. Dr. Guo, today he's operator for the lady, and I have the two assistants, Miss Lin and Jenny Pan. Today we will start to present our case, okay?
This case is an 83-year-old woman with progressive abdominal fullness after previous EUS RFA for a pancreas tumor 10 months ago. She had a mixed type IPNM with malignant change, and she received the biliary metastatic stenting and the EUS Guided RFA on the January 2020. The size of the tumor was stationary 4 months after the previous RFA. However, the study component of the tumor was increased on the 7th month after the RFA. The tumor was located at the pancreas head, complicated with the pancreas duct obstruction. So the patient was admitted for this time for the EUS Guided RFA.
OK，还有一张吧。OK， 好。OK， the lady have received the US RFA 10 months ago, and the purpose for the first RFA is for the pain relief, and besides, we want to make the metallic stent patency longer. 10 months past, the stent still is still working, and because pancreas mass, sorry, the patient has pain sensations increased. So today we want to have a second US guided RFA for the lady. So the operator is Dr. Guo. He has many US guided procedure cases. And he and me performed the first RFA 10 months ago for the lady. So today we will perform again. And before our procedure, is there any question from the Lawrence or other friends?
Okay, I think Hsiu, the questions are still coming, so maybe I can, I think, take you on the, I think this particular case. I noticed that the patient already had one RFA done.
Yeah.
About 7 months ago, at least 7 months ago. So I think, do you think that there was any response to the first RFA?
I think first the pain is the relief, and the second is the tumor size is not increased a lot, only slowly part increase. So that's the purpose. At least we want to stop the rapid progression of the tumor. Is that okay?
Sure. So I think the second thing is, I think the tumor, from the CT scan, I noticed that the tumor is rather big. So is there a limit to the size of the tumor in order for us to gauge whether RFA is a very appropriate palliative method?
Yeah.
Is there a size limit to how much you can actually use RFA to shrink the tumor?
Oh, you mean the size?
Yeah, the size of the tumor.
I think according to the experience of our surgeon, they perform the not US guided, intraoperation RFA. They have many experience. There seems no limitation of their size. Of course, our experience is also limited. Maybe Professor Dongwang saw that he had a lot of palliation cases, but for us, I think maybe no limitation for the cases. Maybe others have experience.
Okay. So I think with a big size, how many sessions do you anticipate, say, these tumors would need?
Yeah, because you know the probe is very expensive, so usually it's a single use. So we are not a repeat. For the cases, if it's our protocol, if the patient have increase in the symptom, maybe we will apply the second time.
Okay.
Okay. It's not so long.
Okay, I think you better go on and show us the EUS, okay? And we can talk as we go.
People, this is Vinay here. Can you show us the machine also, the RFA machine? How do you set it up?
Of course, before we apply we want to inject contrast. So several step of the our procedure. So now, let's go. Dr. Go will explain.
Good morning, everyone.
We can't hear you very well.
It's okay.
Is it okay?
Yeah, I think it's a bit better. Yeah, go ahead.
Okay. Now I am my scope in duodenal bulb, and because as you know, the pancreas, the solid part of the pancreatic tumor is in the pancreatic head. So you can see that the mass is here, and you can see it's compressed biliary tract. So you can see here is biliary metallic stent. Well, I think the previous IFA, after the previous IFA, they caused a partial response. So the stent, the patency rate is very good. Up to now, the biliary function, the biliary stent function is very good. So you can see here is a floor.
Before we puncture, we have to check the vessel.
Right. I think here is a good position. Also now different vessels here. Okay.
So today we use the Fuji Pro. So now we will inject the contrast. Yeah. Oh.
So why do you want to use a contrast, Hsiu? Please enlighten me.
Yeah, yes. Sometimes we will evaluate the effect after the IFA alcohol injection, but not common. Just for the this light demo.
I see.
Okay, let's inject.
We use the sonazoid.
Yeah, we use a sonazoid. And you can see the time. Now it's 12 seconds, 14. Usually contrast should come in around 20 milliseconds. Okay, now it's start. We can see the hyperperfusion of the tumor with some necrosis. I know some endoscopists will perform the IFA for IPMM with solid part only. So contrast can make the differential diagnosis of mucin and solid part. So in that situation, maybe we can suggest a contrast before the IFA procedure. For this case, maybe there are a lot of solid part, so maybe not necessary. But only for the solitary mural nodule, contrast should be not suggest to have a contrast enhanced image. Okay.
So the contrast is helping you to see the viable, the living part of the tumor. Is that why you are doing the contrast?
Yeah. For this case, maybe contrast is necessary. I mean the city tumor with mural nodule to IFA the solid part. But sometimes there's maybe mucus. You don't need to IFA the mucus. So
also help you target the living tissue. So if you have, if you on contrast that one part of the tumor is necrotic, so you not put your RFA needle in that direction, and you will. So
for this case, maybe I will not under contrast guided IFA. I use B mode.
Okay.
Okay. Yeah. Finish. So we will start the machine as requested by Milay. Okay, show the machine. Yeah, this is Hsiu and Farmed companies. This machine is combo, and there's some system because they are a cooling system. So we need to use very cold water. Sorry, and usually 5 degrees, below 5 degrees, and this there are two pumping. There's two lines for pumping system. One is white is in, out is out, and the blue color is in. So he will circulate in the machine, and when we hitting, he will cooling. I think this system may be better because for our surgical department, they use another system without cooling. They make a lot of enteral fistula because no heating and no cooling. And we use the needle. It's 19 gauge needle, and 1 centimeter. Usually for the big one, we use 1 centimeter. Maybe for the small pneumococcus tumor, they have other different size, length of the functional probe. And then we will start the, I will explain. We use a continuous mode, and energy is 15 watts. And our method is we see the bubble. We see when we apply the FA, there are some cloudy, and when cloudy appear, we will stop and repeat and repeat. And we will change the direction of the FA. I think Dr. Guo will show you on the next following procedure. Is there any question?
So what is the size of the burn, Supo? Size of the burn in the tumor?
You mean
yeah. So the
company, the reference maybe 7 to 10 millimeter.
7 to 10 millimeters. Okay.
I use 50 watts. Yeah.
Okay. Okay.
Shall we start? Okay.
Okay. So Dr. Paul, before you start, do you want to measure the size of the tumor?
Okay, let's measure. 先量一下，矮一点，矮一点。OK， 好呀，measure。对，另外一个，这是 at least 5。
Okay.
Yeah.
So your needle is about 1 cm, you say? Your needle.
Yes, yes.
Your burning part is about 1 cm.
Yes.
Correct?
Yes, correct.
Okay. So and in terms of puncturing, you already checked the vessels. Any other precautions you need to take before your puncture?
Before the puncture, I emphasize the breathing because
Sorry?
yeah, breathing is a issue, but we will check the vessel. Yeah.
Okay. So the stent, the metal stent, is it a contraindication? You have a metal stent, isn't it?
It's one issue because somebody say maybe should not near the metallic stent. But for this case, so far the metallic stent is okay. Previously, we have given the RFA for the patient actually very quite near the metallic stent. We worry about the dysfunction of metallic stent, but it seems okay. Yeah. Okay. I don't know if have other doctor have other experience. Maybe give me some suggestion. Yeah.
Okay.
In Supo, you are doing this from the stomach?
No, it's a bulb.
Well, okay. Okay.
Mm. So there was a question, Supo. Do you have any specific location you would not do the RFA, or you can do just any location?
Maybe in the second portion, the probe is a 19 gauge. Maybe the approaching is very difficult.
Okay.
And the another is major. I think the vessel. Vessel is and if you want to make the small one, pancreas duct is another issue.
Okay.
Okay, Dr. Go will start the procedure.
Sure.
Now I already loading the iFrame needle. So can you see the needle? Yeah, it's already showing the EUS.
Can you point to where the needle is? Okay. Using the cursor. Okay, good.
Before the puncture, I already to check no any intervening vessel. So I prepare to puncture just like the FNA. Yeah. I will
Okay.
try to.
So how do you choose where to puncture? The tumor is quite big. What is your thought process? How do you choose?
I will choose the largest dimensions of the tumor part and try to avoid not too very close to main pancreas part. So I now puncture
Yes, sure.
here.
Okay, good.
This
Yes.
and you see my needle is here.
Lawrence, can you see very clear? There are some
Yeah,
markers.
I can. Okay, so you are going into deep in first and then slowly pull back, is it? You burn the one most distal or the furthest away from your puncture site. Is that correct?
Yeah, correct.
For burning start the operation, you need to turn on the cooling system. It's very important because this needle have a inner cooling system. And after turn on, and we can start.
Okay,
Now we start.
So what do you start? You start a generator, is it?
Yes. Do you see the air bubble?
Yes, we do. Can you show us the machine as you start? We can't understand what do you mean by starting.
Yeah, because usually they have pedal, but today is not available. The operator can
Press on the pedal, on the foot pedal, isn't it?
There's a button. Can you see? There's a button. Yeah, my finger.
Sure. We can't see very clearly, but we have to assume. So what's the power setting? Can you just go through the power setting? So you just already fire one, huh?
Yeah, I fire one. Second fire.
Okay, now I slightly withdraw the needle.
I think that's fire.
So now start burning. You can see the air bubble. Okay. So this is the one, and then I will slightly withdraw the needle. Can you see the needle is here?
Yes.
Okay.
Yes.
Okay, I'll take it.
Okay. So I think before you start, explain the fire, all this. You fire the generator. Okay, you press on the pedal or whatever you on the hand, and then the current will go in. How long do you actually burn each time?
Usually,
10
seconds.
10 seconds.
According to your power, because if the power is low, and then you need to burn the timing is you need to increase. Now I change the direction.
Okay. So it's roughly about 10 seconds.
Yes.
And what's the power setting again? I didn't catch it.
50 watts, right?
50 watts, okay.
For 50 watts. Okay.
Oh, this is nice. Very nice. Very nice.
I will try to find my needles here.
Okay, fire.
Okay, and then I will start fire another session.
Okay, there's a question, I think a practical question. They don't quite understand the probe. So they're asking whether the probe is a probe passing through the needle.
Beg your pardon?
No, they are asking about the probe. I think not very clear with the explanation. They are talking about whether the probe passes through the needle or the whole setup is by itself. Maybe you can answer.
No, it's a set.
It's a whole set, huh? Which means the probe is actually the needle. It's a RFA needle. Okay.
Yes.
Okay, there's another one because I think these are all practical questions because they want to show later on whether you can show them the RFA probe itself because they didn't understand the entire probe. Okay, which is also the needle.
So, Lawrence, for the sake of the audience, the probe is actually a 19 gauge probe. It's not a needle. Nothing goes through it. It's shaped like a 19 gauge needle, exactly like that. But the RFA is going through the probe. So there is no separate hole in the probe through which a RFA needle goes. The whole probe is actually the RFA apparatus.
Okay. So maybe I think that Dr. Kuo or Dr. Professor Wang can show us the thing after. Okay, if we have time.
Yes, after procedure, I can show you a needle.
Yeah.
So now I try to change the duration, and just like the Fanny technique.
No problem. And the other way, the other question they ask is, how do you avoid hitting the pancreatic duct?
I think it's a very important question. So before you puncture, I already to make sure the P duct position, and you need to, in some papers show that if you very close, the lesion very close, the P duct, you need to place the P duct stent first to prevent the P duct injury.
Okay.
Okay. So do you give a Voltaren or non-steroidal suppository routinely after the RFA?
Routinely, we will give NSAID, rectal NSAID, and also we will give the patient a foil.
Okay.
That for prevent pancreatitis, and another we will give the prophylaxis antibiotics.
Okay.
Okay. So Dr. Kuo, what are you doing now? You already hit one line. Are you adjusting to another track?
I already changed the 4 different directions.
Yeah, yes.
So because this tumor is quite big.
Okay. Is there a limit to how many times how many burns do you do per session?
Good question. The company tells us it's 10 times.
10 times.
Yeah, but last time we 30 times.
So what actually stops you from doing more than 30 times?
Last time?
Because, yeah.
Yeah, I think last time we burned the most part. So
okay.
Yeah, so it takes times.
Okay, so you also will burn most parts today?
I think time maybe according to Vinay.
Okay, according to Vinay.
No, we need Super. We need to see your probe once we finish this, so that people can appreciate how it looks.
Only 5 minutes remain, so we
no hurry, no hurry.
Needle, okay.
So there is another probe, Habib probe, which goes through the needle. I think that is why people are asking this question. There is a very thin probe which is available in Europe and USA, the Habib probe. That probe is passed through the needle. While this probe which Supo is using, it is the probe itself is like a needle. That's an advantage.
I beg pardon? I know we have also a EB system because our surgeon, they use the HABI system because of no cooling. So I think they make a lot of trouble.
Yes.
Breathing. Of course, they don't use EUS Guided. So I think the EUS Guided procedure is more safe. And the system is bigger, not easy to operate. However, I think it's safer because the cooling system. This is my opinion.
Yeah. Right.
I think that will make a very good cloudy of the humor.
Yes. So if you have a lesion in the uncinate process, because this is a big probe, you probably cannot target it very well. So that is the only indication where I feel a Habib probe is better, because it is thinner, probably can be passed for uncinate process tumors also. But otherwise, I agree with you. This is a very, very good RFA probe which you are using.
Vinay, I have one question. You have demoed the alpha method. Sometimes we can check the Ushina process from stomach.
Yes.
How about this situation? Can we use this? Maybe
no, because you can see the uncinate process from the stomach, but there is a big vessel between the stomach wall and the uncinate process from the stomach. So you have the SMA or SMV coming between the stomach wall and the uncinate process when you see it from the stomach. So it will be risky to do RFA through the stomach for uncinate process lesions because there is a big vessel which is coming there.
Okay. So after the fire, we will to show to the participants.
Yes, and are you going to do a contrast again to see what is the area of necrosis?
那个 contrast 准备一下哈，再拉出来再烧一次，我们等一下就继续烧了。contrast， 再烧一次就出来了。
Okay, Hsiu,
Hey.
a question, a very quick question while you get the contrast ready. RFA, besides palliation, do you ever use it as a curative procedure?
Yeah, so far the for the neuroendocrine tumor in my center, the alcohol is the first choice. We still not apply this for cure the neuroendocrine tumor. But for the small pancreatic cancer, I think I have no experience because even the 1 centimeter pancreatic cancer, even after the surgery, sometimes recurrent or metastasis. So I have no experience for the small pancreatic cancer, but for the neuroendocrine tumor, I think it's a very good indication.
Okay. So any contraindication for RFA?
I think the basal and for the cure, I think it's just a basal. Okay. And the bleeding maybe is another region, like EUS FNA. Yeah. Do you have any other suggestion?
No, I think, yeah. No, I think essentially it's correct. I think the contraindication for RFA is similar to contraindication for EUS FNA, essentially. Okay, the needle size is, the RFA needle size is about the same size. Okay, and the rest is all burning, which we have to avoid. Okay, you finish the thing, you're doing the contrast now, are you?
Yeah.
How many burns did you do just now? Total?
Good
response. You lost count.
Good response, I would say. Super, what do you say?
18.
18, huh? Okay. You injected the Sonovil already?
Wait, now you can see the timer. Okay, start. Yeah. Okay. But we will continue to ablate the tumor after our section.
Okay.
Because during your lecture.
Okay.
Please show
How
us
many seconds now?
Needle also once.
Okay.
Oh yeah, we can see that now. The contrast. Good.
So now perfusion part. Yeah.
Yes. Yeah, this is the necrotic part.
Okay.
Okay, very good. So can you show us the needle? The needle.
Yeah.
Can we have the room view to see the needle?
Of course. We will change the screen. Okay.
Okay, good.
Close. 哎，我身体这边要伸出来啊！我要摆点的。Okay.
Yeah, we can see it now. Thanks.
Yes. So it's just like FNA. It's a FNA.
Yeah, actually yes.
And that is the RFA part, no? You can see different part there.
Yeah.
Okay, we can see that. Thanks. And there's a shift there, isn't it? There's a blue shift.
Yeah.
To insulate the current.
Later, and the keep 1 centimeter is the functional part.
Yeah. Okay.
Okay.
Fantastic. Supo, there is a good question from Rinaldi. Do you use it in combination with chemotherapy? RFA plus chemotherapy.
Yeah, very interesting. This patient, she refused chemoradiotherapy. So
Okay.
during 10 months, she didn't receive any treatment.
But the question is, can you combine it with chemotherapy?
Of course, we can.
You have some protocol where you are advanced tumor, you are doing chemo plus RFA or something like that.
You mean the because RFA in my hospital is palliation only.
Right.
So the people will receive the chemoradiotherapy, majorly treatment. Of course, RFA have evidence to induce the oncoimmune
Right.
it can increase the oncologist's immunostate response.
Yeah.
So in the maybe it's another immunotherapy. Yeah.
So I think what Rinaldi is trying to ask is, in advanced cases, when you give chemotherapy for palliation, that is the standard now. So if you combine chemotherapy and RFA, do you get better palliation than with chemotherapy alone? I think it's a very interesting question.
Yeah, I believe. Yeah.
Yes.
Okay, super. I know you're going to go on and burn it. So assuming that you finish burning, another 30, total 30 burns. And what do you do after that in terms of the following up on the patient?
Yeah, we just follow up on the next day in my hospital. We usually perform the ultrasound to check any local complication. Even though we will follow up the patient every 3 months, because the patient will not undergo any chemoradiotherapy anymore. So we just support care, and we will also check the metallic stent. Pattern or not pattern. So far, I think the metallic stent is okay. Yeah, this protocol.
Okay, when do you expect the size to shrink? Because Rinaldi is asked, sometimes it becomes bigger after the RFA.
Yeah, the beginning. But usually after the RFA, maybe sometimes we're shrinking. Sometimes the bigger is due to the necrosis expansion. So, if we have a next EUS evaluation, we will still use a contrast to see even if the increase is a true increase or not true. Yeah.
Okay, just very quickly, I think there's also from a Q&A, how many types of sizes do we have now in the market? Sizes of probe. You are using the 19 gauge.
Yes. You mean, I beg pardon?
No, the size of the probe. How many sizes are there in the market currently?
Marker.
Only one. Only one. It's
okay. So you cannot choose essentially. There's no choice. Okay. So that's where I think Vinay one. I think for a deep in the D2, D3, you have to use a heartbeat which is thinner because you have no other choice. Okay.
Bring a thinner probe also. So hopefully we will get a thinner probe also soon. So yeah, but currently we have only 19. Super, I'm right?
Yeah.
We have only 19 gauge right now.
Yes, yeah.
That's a fantastic demonstration, both from the Taiwan team. We really learned a lot.
Yeah.
Thank you, Supo. Thank you, the team, the Taiwan gastroenterology team. Very nice educative experience for us. And you finish this and then join us back again. We are continuing with other lectures and live cases. So,
okay. Thank you.
Thanks a lot.
Oh, thanks, Super. Fantastic. Dr. Guo also, very good demo.
Thank you, Professor Lawrence. Thank you, Professor Wang from Taiwan and the Taiwan group. We're going to move on to Professor Lawrence's lecture in Singapore. He's a professor and head of the Asian EUS group and gastroenterology at the NUH. He's going to talk about teaching and training in EUS, interventional EUS. Over to you, Professor Lawrence.
Oh, thanks a lot, Rahul. I think am I allowed to share the slide now? Sometimes
yes, sir. Yes.
Okay, good. Okay, so I think I believe that you can see my slide now.
Yes, sir.
Right?
We can.
Okay, good.
Yes.
So I think we just went through a very nice demo about on RFA. Obviously, I think a lot of people, I think there are quite a number of people signing up for this webinar. So I think some of these people may want to learn and some may want to teach interventional EUS in the near future. So I think we are all here to learn. Obviously, I'm also learning. And certainly, I think if you look at the entire, the whole schema about doing interventional EUS, essentially there are three parts to this sort of scheme of doing interventional EUS. I think firstly, you do have a patient who has certain conditions which require the procedure to be done. Similar to our case just now, I think the RFA, there was a tumor and the patient needs some sort of palliation. Unfortunately, I think the patient's, all the factors, the patient's factor cannot be altered. Okay, they are quite unique to the patient. And so I think we can't, at the moment of medicine, we cannot change anything as far as the patient is concerned. And then comes the other aspect of this procedure, which is I think the procedure itself, the scope, the image and so forth, and as well as the accessories and so forth. So I think this is the reality is that interventional EUS currently is still quite a complicated procedure, has carry increased risk of complications. Okay, so for instance, RFA, we learned from Hsiu just now, there's a risk of pancreatitis, risk of puncturing into the vessels, and also, again, I think risk of burning, I think targets organs and so forth around it. So if you look at just the biliary drainage procedure itself, there is a complication which is relatively high, 14%. Okay, and then the procedures can also fail in up to a third of our cases, and this is why I think the middle part cannot be changed. So this is where we are left to try to modify the only factor which is modifiable at the moment, and that is the endoscopy itself. Okay, himself or herself, and this is the reason why we are here today, to try to learn something. Okay, either as a student or as a teacher, to see whether, I think in order for us to achieve a better outcome, whether by training, by learning today or other days, we can actually make ourselves better. So I'm going to kind of borrow from Claudia, who is also a faculty in today's webinar, about how to train a doctor in doing interventional EUS. So I think according to Claudia in his particular book chapter, essentially, I think the right way to EUS training is based on all these 4 different steps. Okay, I'd like to actually share with you the different steps over the next few minutes. So firstly, I think he's right. We need to select the right person to do EUS training, because I think, as I mentioned, we can't change a patient, we can't change a current procedure itself. So we have to actually do training. So who is the person who is appropriate or suitable for EUS interventional EUS training? So this is where I think there is a recommendation, okay, based on the American guidelines. Okay, this is a consortium meeting and published in a World Journal of Gastro. It's still appropriate. So essentially, it listed 4 different criteria about choosing the right person to do it. I think most importantly, foremost in the 4 criteria is the place of work itself. So meaning that the person should be working in a particular center, okay, with adequate backup, including interventional radiology as well as surgical backup. And the reason is very obvious. I think the backup is required because we can't actually stop complications. But what we can try to do is to prevent and manage complications should they occur. That's why it's very important to have our colleagues backing us up in a particular center. So I think that's very important. So the other 3 factors, which are based on the American recommendation, is actually to do with the person himself or herself. And the person essentially is kind of can be summarized into the person should have had experience doing ERCP and EUS before he or she embarks upon trying to learn interventional EUS, and that's also quite straightforward and obvious, really. So I'm going to just run through the reason for the experience based on the Asian EUS group consensus guidelines, and this was published in GUIDE, I think 2 years ago. So essentially, I think according to these guidelines, I think the experience in EUS and EUS FNA is essential, because I think a lot of this procedure, interventional, is actually based upon just EUS and EUS FNA. As shown in the live demo just now, I think you need to be able to locate the tumor, the size, and so forth. So I think no reason to do intervention if we can't even do the basics. And then the rest, I think all this procedure like wire manipulation, stent placement, they're actually essentially based upon the FNA platform. Similar to RFA is based on the FNA platform. You need to puncture and so forth. And then the wire and stent as well. And then without actually saying, again, I think experience in ERCP is required, because we are actually following the ERCP procedures in using many of the accessories. We don't have a kind of a unique procedures, sort of two unique procedures. So a lot of things like pseudocyst drainage, again, if you look at it, I think the instruments and techniques are borrowed from ERCP. Okay, that's where the ERCP scale will be. I think a proficiency in the ERCP scale will be beneficial for the endoscopists who wants to do procedures such as pseudocyst drainage. So I think this is kind of basically summarize the first step. Okay, for those people who want to learn, they need to be proficient in EUS and ERCP, and also they need to work in a center with adequate backup to prevent and manage complications. So next, I think we go into the nuts and bolts about how to actually, if we have chosen the person is the correct person, and then so forth. And then the next step will be to try to learn, I think, about the intervention. So that's where I think some sort of basic knowledge is required before we do the hands-on part. Okay, so today, obviously, I think we are doing one of those theory part. It's a mix of theory, but today's session is actually quite practical. So I think the webinars have been organized almost every month by the Asian EUS group. I think Vinay and Anthony have championed all this. So I think these sessions are good because they actually go through very quickly, very practical tips about how to do interventional EUS. I think there were previous sessions, stents as well. So I think the sessions cover very unique and very specialized topics, so that people can go in depth into this sort of procedures. And also, I think obviously, I think people have the chance to share experience, because sometimes I think despite what we know about EUS, there are also a lot of kind of so-called fine tips are actually based upon experience, really, because I think it's a question of the volume now. So I think I like to actually take this opportunity to congratulate Vinay for again championing this sort of sessions today. So moving on, I think we have other publications as well, which are very important, because publication helps to move towards the what we call finally coming up with some sort of practice changing, practice improvement, and so forth. And then again, I think eventually all these practice changes can then be consolidated through what we call position statements and consensus. So these are actually evolving field, and certainly what they are trying to do is to hopefully minimize potential, I think, complications through a period of learning as well. Okay. So I think moving on very quickly is, I think after having learned a bit of basic knowledge, I think the trainee still will need to go through hands-on training. Okay, and that's where I'm going to spend a bit of time on going through essentially is how do we actually do this hands-on training. Okay, given the background issue of complication and so forth. So certainly, I think very few of us are prepared to let the beginner trainee to go straight into real patients, because I think of the risk involved. So that's where the starting point is always to try to give an intermediate phase of simulation-based training. That's where I think certain groups, I think such as our Asian EUS group, has a kind of role to play, because I think the group emphasizes a lot on hands-on training. Okay, that's one of the key features of the training undertaken by the Asian EUS group. And what the thing has done, I think before the COVID time, obviously, when we could come together, I think we have created a number of models. Okay, so one example is the pseudosis model, which centers are encouraged to come up with their own version. Okay, you've got different versions. I think there are strengths and weaknesses as well, as you can see from this slide. And certainly, I think all these are actually quite useful for people to get a hang about, I think, the way this should be done and so forth before they embark upon training on real patients. So you can have all these models really borrow from ex vivo models, and some are actually totally based upon artificial models. Okay, so that's the pseudosis model. And then you also have, obviously, I think the biliary drainage models. Okay, so Vinay came up with this model a number of years ago based upon 3D printing, and which allow the drainage training to be done under fluoroscopy, such as this thing, and that was published. And more recently, I think he modified and improved upon the initial model and came up with the Mumbai model 2, which is a hybrid between 3D printed as well as the ex vivo model. So again, I believe this was published. So all these efforts are actually geared towards, I think, providing a viable training model for future trainees who like to embark upon interventional EUS. And yeah, the models have been used. I think they're not just for show. I think they have indeed been deployed into many workshops. Okay, hopefully I think they will be shown to be effective. And we also have the model from Japan, which is currently, I think, been deployed in many of the AEG workshops, such as the KIDA model, which is based upon totally, I think, no ex vivo model, is totally replaceable, and you can actually replace this thing as you go. We just learned on from Hsiu's thing, an RFA, and there's certainly a RFA model for those people who are interested to learn. You can actually do it using kind of ex vivo model. I think the one is here who used that model during one of the training workshops in the past. So moving on, I think apart from the acquiring the skills through the knowledge and also through hands-on training, I think it's a key part of training program is actually assessment. Why this is important is because we do need to know whether the trainee knows what to do after the training. And also, we also need to know at the same time, if you're a trainer, whether our training program is effective. So this is where I think we try, the Asian EUS group did try to do some sort of assessment in the past. Okay, so where we got a kind of a templated form to score the trainee as they go through, and then also to track their learning curve as they do all this. So one of those things we used in the past is the KIDA model. Okay, and that is the form we use, which has certain learning objectives. So they have to go through certain learning objectives to see whether at the end of the training, whether they already are quite skillful in those particular skills. The British also came up with their own. I think that this is not specific to EUS. This is actually generally applicable to any endoscopic procedure. So they have this thing called direct observation of procedural skills, where the trainer will observe the trainee going through, and then they observe the trainees progressing over months of training to see whether there is an improvement over time, okay? To make sure that eventually, once they cross the threshold, then we know that this trainee is actually competent to perform the particular procedure. So lastly, I think just share with you the ASGE way of doing assessment as well. So they do have a assessment tool, which is called TSEC, okay? So apparently this assessment tool is validated in terms of assessing both the technical as well as cognitive competence in a continuous fashion. So again, I think a lot of emphasis is placed upon continuous improvement, in the sense that certainly I think there is a learning curve, and the procedures will be tracked over time to make sure that the trainee is moving in the correct direction, and then regular feedbacks is given to the trainee to ensure that I think the program is actually effective. So lastly, just want to finish off very quickly to touch upon the so-called supervised training. This is based on Claudio model of training intervention in the US. I think finally, I think we cannot replace this part, which is a crucial part, okay, about learning or training on intervention in US. At some stage in the training process, I think certainly we need to provide a way to for the trainees to do on real patients. Okay, so this is where I think Vinay has tried to do this. Okay, in his center, I believe that they have this EUS school, which was started last year in April of last year, and this particular school is actually quite structured. Okay, with the syllabus to ensure that I think the trainee can be given eventually. Obviously, they go through a continuum. I think eventually there's opportunity for them to do practice on the live patients under close supervision. Okay, so finally, I just want to kind of finish off to briefly discuss about the number of cases in order for a person to gain competency in intervention EUS. Okay, so currently there's no consensus. I don't think there's any kind of published thing, but we did actually try to hazard a number when I think the Asian US group led by Anthony Teoh in his consensus wrote in the consensus paper. So essentially, I think we believe that I think a performance of 5 to 10 supervised procedures is actually required in order for a person to gain competency. Okay, so this number 5 to 10 is not actually plucked from the air. It's not. Okay, there's some basis for that. Of course, the basis is not very strong. We do acknowledge that, and the basis is because I think based on a few studies, I think Sham and as well as Harvard studies, to say that I think if you look at people performing, this is just unique to pseudocyst drainage, but I think it also can be generally applicable to other interventional EUS procedure. So if you look at the resolution rates, meaning that if you track a person who is competent to do it, okay, then the first 20 procedure, what they found is I think the outcome of the pseudocyst drainage actually were significantly improved after the first 20 procedure, meaning that it's better than the procedure after the first 20 is better than the outcome from the first 20. Okay, so after post 20 procedure, somehow have better outcomes for the patient. Okay, compared with the first 20 procedure. And also at the same time, I think after the first 25 procedure, they also found that the time taken to complete the procedures was shorter. Although there's no difference in terms of the other things, the technical success and so forth. Okay, and also the adverse events. So I think that's where I think the thing about half the procedure maybe is at least minimum in order for us to be able to come up with this number. Okay, so I think finally, just like to summarize what I just mentioned, I believe that I think to become competent in interventional EUS procedure, I think the trainee should have had prior experience in EUS and ERCP, and also should be working in a center with the setup and also the backup to minimize, prevent complications. And secondly, I think the intervention EUS skills are best acquired through initially observation in high volume centers, followed by hands-on training in models, simulators, and also finally supervised training on real patients. Okay, so I think with that, thank you very much for your attention.
Thank you, Lawrence. Thank you very much for that wonderful overview of teaching and training. I think Asian US Group was very early to recognize the importance of interventional EUS, and under your leadership, we formed the first interventional EUS group as early as 2013, if I
That's
remember.
right.
And we came out, we went about it scientifically, setting guidelines, simultaneously doing models and workshops, and that is all thanks to your vision, your leadership.
Thank you. Thank you. I think it's a team effort. Obviously, your effort as well.
Thank you. Thanks a lot. I don't think there'll be any questions on this, because this is an evolving area, very, very exciting area, teaching and training. So thanks a lot.
Thanks again.
Thank you very much, Professor Lawrence. We're going to move on to the next session. We're going to have on the moderators on stage. Can we have Dr. Y.T. Lee and Professor Raymond Tang from the Chinese University of Hong Kong? We have Professor Anthony Teoh live from CUHK. Professor, you're live.
Hello.
Hi, Anthony.
Good morning, Anthony.
Hello. Can you hear me well?
Yes, very well.
Okay. So we're going to have a live case today. I think Shannon's going to be presenting. Is she here? Thank you. We can start from the second slide, I think. You can start from the second slide, Shannon. Shannon, we cannot hear you.
Shannon, you have to share screen and make it full.
Yeah, Shannon, I think you are muted.
There is some technical issue. Can you give me a little bit of time? I can't move
Okay.
No problems, no problems. So what is the case in general?
Well, anyway, so this patient is a patient with suspected pancreatic fluid collections. We are going to do a EUS guided pancreatic fluid collection drainage. Okay, I think Shannon has sorted out the technical issue.
So this is a 58-year-old female. She came to us 1 month ago for a self-detected epigastric mass. It's been there for 2 years. She denied any history of pancreatitis or trauma. And on physical examination, it showed a 10 centimeter left upper quadrant mass. So CT scan had been done, which showed a unilocular cystic lesion at the pancreas. And that's why we performed an EUS aspiration for her. So on EUS, we found a 10 centimeter unilocular cyst with no solid component. So we attempted aspiration of this cyst to send for chemical pathology. So we aspirated thick brownish fluid out. String test was negative. We tried to send for CEA, amylase, and glucose, but they were rejected by the lab because the fluid was too viscous. And we actually repeated the procedure again and tried to send for CEA and amylase again, but they were again rejected due to the viscosity. And that's why we decided to discuss with our HPP surgeons and our radiologist. And the conclusion is radiologically, it seems that this collection is likely to be a pseudocyst, although a small chance of mucinosis cannot be ruled out. So the conjoined decision of this MDT was to perform an EUS guided drainage for this patient first. And this has been discussed with the patient and she agreed. So today we will perform the EUS guided PFC drainage.
So before we proceed, why don't we just dilute the so-called viscous fluids for analysis?
Well, if we dilute it, I'm not sure if it's going to affect the lab results.
But however, pseudocyst, the immunase level is supposed to be very high. You dilute, for example, 5 times, it still will be very high, and give us some clue that what it is to be a pseudocyst or a cystic neoplasms.
Yeah. I guess that's one option. Although we repeated twice, the aspiration, we weren't still able to get any
so Anthony,
result.
You aspirated through a 20 gauge needle, or you needed a 19 gauge needle?
I can't hear you. Sorry.
Could you aspirate the fluid with
19 gauge? 19 gauge.
You needed a 19 gauge, so it was a fluid, viscous fluid.
Yeah. So anyways, I think this case we can also look at the EUS and have a discussion on the findings and see what everyone thinks. I mean, we don't have to do a drainage, although the patient has been consented. And I also discussed with the HPP surgeon if just in case the cystic lesion persists after drainage, then he is happy to do a distal pancreatectomy plus a wedge resection. So this has been discussed with the patient. For her, she just wants to have her symptom relief because she has a epigastric mass and she feels very distended. So these options have been discussed. So can you pin on the EUS image? I think it was shared to the panel.
Yes. So Teoh, quick question. This is Raymond. So any role for the Morris forceps in this case?
Yeah, it's quite a large lesion. At that time when I was puncturing, it's very deep. So I'm not sure if I can see the Morris forceps very well. Also we have discussed that if the lesion persists after the drainage, we can certainly use the luminopulsing stent as a way to go in the cyst and get some cyst wall for biopsy as well. There's another option. So this collection is right here. So Vinay, what do you think? Does it? How do you feel?
A pancreatic fluid collection, pseudocyst.
It looks like a fluid collection, right?
Yes, yes.
It looks very unilocular.
Yes.
There is no abnormal thickening of the wall.
Absolutely, absolutely.
So if I am worried about a cystic neoplasm, there should be some solid component or some growth from the wall. So far, it looks very unilocular.
No lymphatic material or whitish material came out, no? The other thing is...
No, it was a very thick, almost like necrotic material, necrotic pancreatic material.
Okay. But there are no you are right. There is nothing to suggest that it is a...
so it looks very pseudocyst-ish. So, so that's why after we discussed with HPP surgery as well as radiology, we think that it looks more like a fluid collection.
Yes.
All right, so I'm going to be using the hot Spaxus. I think some of you may not have seen this device. Can we have my external view as a big view? Can you pin that? Oops. Thank you. So the hot Spaxus is very similar to Axial, the design. So you can see the tip. There's a metal area, right? And then the stand is mounted on a usual 10 French delivery device. In terms of the handle, it's a regular deploying mechanism. So I have tried this device using a direct puncture. So it goes in very well, quite similar to hot axials. But the price is half of the price.
Yes. Anthony, we want you to show us your scope, where it is, your scope position on fluoro.
Okay.
Puncture.
So can you also show the fluoro view? Can you pin on the fluoro view? So it's quite a big lesion. So there are various areas I can puncture, like from here
Oh, it's a
onwards all the way. But because if I puncture too high, like right here, the cyst will collapse and will pull on the stent. So it will cause a separation of the two walls. So usually I tend to puncture a bit lower, maybe around here.
And the bend in the scope, you know, there is a bend now in the scope.
I know there's a bend, but if I straighten it altogether, it's a bit like that.
Right.
Yeah, I think we can, maybe somewhere around here is a good compromise.
Okay.
So your scope is in quite short scope position. Is it? Are you in the antrum or are you in the duodenum?
Antrum.
Antrum.
Well, mid body, I would say. Yeah.
Mid body.
Yeah. So okay. So now you can go back to the EUS view. All right. So I think this is a good position for puncture.
Do you worry about the vessels, those small vessels which we are seeing?
Well, if it's just small vessel, I'm not too worried. If it's a big one, sometimes these big vessels can be like that one. That is, I would try to avoid that one.
Yes.
Okay. So I'm going to turn off the, so you can see my delivery system coming out from there. Right. Okay. So this is a hot Spaxus. So I'm ready to puncture. So it works very similar to with the what do you get? Axial. So first I burn. Okay, it's not burning in very well. Okay, it just went inside, right there. All right, so it's inside. Okay, so I'm going to open the stent.
So Anthony, just to understand, when you are applying the current, do you force to push the stent through, or you let it go very slowly into the cyst cavity?
Yeah. So first of all, I would burn it a little bit, just to make sure that I have an indentation on the wall.
Right.
And then I would go through the wall slowly.
Okay.
So my plan is to insert a double pigtail.
Okay, through it naturally.
Yeah. So we're gonna have the wire going inside first.
By using a hot stent, you have avoided lots of steps.
Yeah.
Wire,
avoided a lot of steps.
Later, so that is good. That is nice.
Okay. So my nurse find it a bit difficult to insert the wire, so we're going to change to an 025 wire. Okay. Bit difficult.
So why you need to insert the wire?
I want to insert a double pigtail. So I might as well insert the wire now. The other option is, of course, deploy the stent first and then do everything afterwards. So two options.
I think inserting the wire first is a good move, because if there's a gush of fluid, so it's hard to cannulate sometimes. So yeah, I think having the wire in first is a good move too. So Teoh, is the patient under GA or MAC?
Okay. MAC, but of course, if you're worried about a lot of fluid, then you may want to insert, perform it under general anesthesia. All right, okay. So anyway, somehow this device, the wire doesn't go through very well. So we're going to deploy the stent first. Okay, can we open the stent?
Anthony Rinaldi is asking why not place a plastic stent and why put a metal stent? But I guess a plastic
Yeah,
is not going to work, no? It's very thick fluid.
yeah, very thick fluid. That's one. Okay, let's open the stent.
Can you show the how you are deploying from the point also?
Can we show the nurse hands external view?
Okay.
Can we show the nurse hands when she deploys?
Okay. So slowly, because
and
we are one moment. Okay, stop. Okay, because okay, so because we don't have a full AV team, so I need to do everything by myself. One moment.
Sorry that.
Okay, so I'm gonna try to show her hands.
Sorry to trouble you.
No problem. Okay.
Yes.
Fantastic, fantastic.
Okay. Why is it important? Because it seems that there's no the few steps.
Okay,
that,
so can you pin the USB again?
Okay.
Pin the USB.
Show the EUS.
EUS.
All right. Okay. Hold on. Hi. So I am also looking at the X-ray images. So I can see the stent slowly opening. Okay. So I'm almost at the halfway mark. Okay. Okay. Stop. So now you can see the Spaxus completely open. The distal flange is open. So I will pull back the Spaxus right there.
Anthony, sorry. Where is the halfway mark? If you can, is it possible?
You're in the halfway mark, so you can also show the X-ray. Can we pin the X-ray? Thank you.
X-ray, please.
Can we pin the X-ray?
Okay, show the
So this is the halfway mark.
Okay.
Right there, can you see the black mark? Yeah.
That's next to the scope, isn't it?
Yeah, next to the scope. Okay, so can we go back to the EUS view? So I'm going to do the intra-channel deployment. So I'm going to ask the nurse to continue to deploy the stent. Okay, open.
Can you describe what you are doing?
So we are deploying the stent within the channel. So she is opening the stent slowly.
Are you pushing?
And at the same time, I am pulling the delivery device. Okay. So now the stent is completely deployed in the channel. Okay. I'm going to change to endoscopic view. So I'm going to push out the stent slightly first. So you can see it should be coming out at around 12 o'clock. So you can see around 12 o'clock, already some fluid coming out.
Yes.
So the fluid is very thick. So my device is right in front of me.
So do you pull the scope a little back at this time? Or
yeah, I'm pulling the scope back. So I'm also trying to see on X-ray view.
Lot of fluid.
Lot of fluid, so I cannot see very well.
This looks like blood. Heavily bursting the fluid.
Okay, you can see the stent right there. Yeah.
Yes.
Yes.
All right. Okay. All right. Okay. So because I have no wire here, so I'm gonna need to cannulate the stent again. So let me clean the scope first. All right. Okay, better. All right. So now the view is a little bit better. Can I have a sync total with wire? Thanks.
Very thick fluid, huh?
So what do you guys think?
Very chocolatey.
Yes. It doesn't look like the typical mucinous cystic fluid.
It looks like hemorrhagic cyst that with altered pus content in the cyst.
Yes, it looks like a pus, dirty pus. I don't know.
Could the appearance be altered after prior FNA?
I think for the 2 times that I've done it, it looks very similar. So I don't think I have caused any bleeding from the cyst.
Anthony, what I normally do is, and it takes a little more time, is that at this stage I exchange the scope to
Regular scope.
double channel scope. It helps me with aspirating everything. The EUS scope somehow is not very efficient in sucking.
Okay, now I'm sucking quite well, so I think I'll continue to suck first and try to suck out all the fluid. I can always go back to the ultrasound view and take a look how the cyst is collapsing. So still a fair size. That's the stent.
Right. Would you dilate it now, Anthony? Or would you...
Well, usually I don't. I think there's a bit of a wasting right there. If I'm planning to insert a pigtail, I'm worried it might get caught somewhere there. So I'm gonna put in a wire first.
Right. There is a question about cautery settings, Anthony.
Yeah.
What were the cautery settings?
It was a Irby pure cut, effect 5, 120 watts. Okay. It seems like there's still a lot of fluid coming out. It might be difficult.
Yes.
So I think I need to suck out a bit more of the fluid first.
Anthony, is there any risk of sudden collapse of the cyst like this size?
Yeah, of course. I think some people worried about the edges of the stent causing some irritation.
No, I mean if in the abdomen something so big, it suddenly collapse. Is there any effect in the surrounding structure? Like I don't know. I just wildly asking.
Yeah, I don't think so.
Okay.
And we have drained some huge collections. Actually, the patients are very happy, and I don't see any even effects on the organs.
Oh, wow.
Ah, that's good. That's good.
Relax, Father. Someone they want. Okay. So let's see if I can do this without the OGD? Okay. Relax. Oh, okay.
Now I can see that why you want to put this guide wire first.
Yeah, because it's not easy. All right. Looking straight on to you.
Quite tight, huh?
Yeah, quite tight. Oh, relax. Okay. So I'm gonna manipulate the knife so that the direction is more favorable. Okay, why? Okay, good. Okay, so do you I think the wire is inside.
Let's see the fluoro view.
You may have go through some wires, not lumen.
I think so. Or someone. Okay, sorry. Someone. Seems like
the direction.
I'm not sure oh, okay, it's going in. Okay, good. The body. So okay, the body. Okay, exchange. The body. Look for them. Okay, exchange. Okay. Exchange. Ba cậu sập. Màn đi. Okay, so I'm going to dilate it because I think the plastic stent might get stuck.
Right.
Ba cậu sập. And then I'm going to insert a 8.5 French double pigtail.
So Anthony, is this Spaxus stent sturdy enough to pass the scope in this thing? Or you think you would like to wait? Suppose you want to go inside.
Yeah, we try not to do too much manipulation in the first drainage because there's always a risk of dislodging the stent.
Right.
So usually I will wait a little.
Okay.
Yeah. So usually there's always this question of when to remove the stent. I think for Spaxus, we noted that the lumen opposing power is not as strong as the axials. This might be a good thing because it might be associated with less complications like very stent syndrome or erosions. And in our previous study, we actually found that the risk of causing complications in the long term, even if we don't remove it at 4 weeks, seems to be a bit lower.
Mhm.
So, of course, we all know from Hsiu's study, he experienced a lot of complications if we left the stent for more than 4 weeks. But seems like for Spaxus is a little bit better. I don't know. What's your experience? Other people, Renee and other people.
We published, I think, in 2015 that we remove very early.
Yeah.
Even we used only Nagi, we didn't use.
Why? So do I. So do I.
There is no advantage of keeping a stent longer, actually.
Yeah.
Beyond 4 to 6 weeks maximum. There is a suggestion, Anthony, from Pankaj. Would you like to place a nasal drain and irrigate the cavity?
Well, of course, if you are worried about infection, this is one option. But this patient is outpatient, so I don't think. Okay. So we're gonna dilate. I don't think she wants to stay here for the nasal cystic catheter. So. Okay. Yeah. Okay. The connection came loose. It's a contrast, so you have contrast on your face. Yeah. Okay. So this is not a stricture, so I think we don't need to keep it for 1 minute.
So you use CRE or a hurricane? What did you use?
This is a CRE balloon, so we dilate up to 10 millimeters.
10. Okay.
Yeah. So I think just now there was this question on whether we could use plastic stent. I think we can use plastic stent, but this is very, very thick fluid. So you need to insert a couple, just in case it gets blocked. Okay. All right. So I'm going to insert the plastic stent now. Exchange.
Oh my God, this is really thick.
Very thick, yes.
There's one question that in dealing with this large pseudocyst, do you want to intubate the patient to prevent aspirations?
Yeah, that's of course one option. So if you are very worried about aspiration, then yes, we should intubate.
So we always intubate.
Sorry.
Any cyst which is like this cyst, where it is patient has detected the cyst. Here, patient found that there is a lump. So obviously it is a very big cyst. So such bigger cysts we always intubate, so to prevent aspiration.
Yeah.
It means if a facility is available, we should consider intubation of these patients.
Yeah. So possibility of hemorrhage into a cyst, I think it's possible for this patient.
Unlike the way you showed, it didn't appear very vascular or anything to me. So
yeah,
the interesting.
And now the fluid is a bit more clearer. It's still very serious feeling, so it doesn't feel like nuisance to me. So
there's a question.
Hopefully, we don't need to do a pancreatectomy.
So another question from the floor, and
yes.
What would be the best position, supine, prone, or natural positions for these patients?
I'm having the patient prone. I think if you have general anesthesia, then I think supine is also possible. I think some people would do it lateral as well. It depends on your preference. Vinay, how do you do it?
So we do it lateral and then if needed supine.
Yeah, I have it. I have a prone because of course I'm worried about aspiration, so that's why.
So the question is, what is the size of the stent used? From Ellie is asking the question.
I can't. Can you repeat that? Sorry.
What is the size of the stent? So it's a standard.
This is a 16.
And
so I worried about blockade of the stent, so I use a large size.
Okay.
I will save some aspirate for analysis this time.
We can, but we've saved a couple of times, so.
This is a very interesting. Anthony, you have to give us the follow-up as to what is the etiology. What is this cyst?
Yeah. Okay, I think the marker is already all in.
Yes.
Okay, hold on. So. Okay. All right. So we finished. I think Shannon is ready to give her lecture. So thank you.
Thank you very much.
Thank you.
Thanks, Laura, Anthony. That's fantastic.
Some more questions. Because this hot Spaxus is not like hot axials that with different steps in opening. So we rely on the middle mark that you mentioned to indicate that this is halfly opened, isn't it?
Yes, you can also see it on EUS view. So because the flange is open, when it's completely open, you can see it in the EUS view, and then you can pull it back. So
the trick is ask the nurse not open too fast.
Yeah, of course.
Okay.
Yeah. Okay.
Okay.
Thank you.